Hello, everyone, and welcome to this new edition of neonatal ventilation webinars. With us today, we have Dr. Gianluca Lista, Director, Head of Neonatology, Pathology, and Neonatal Intensive Care at the Vittore Buzzi Children's Hospital in Milan, Italy. Today, he's going to walk us through describing the modality to monitor lung aeration in the delivery room and the NICU in mechanically ventilated infants with respiratory failure, and really some of the errors and adverse events related to the mechanical ventilation in the neonate. Dr. Lista, welcome, and the floor is yours.
Thank you very much. Good afternoon to everybody. Can you hear me? Can you see my presentation?
Yes.
Perfect. So my talk today is about the errors and adverse events related to mechanical ventilation in the neonate. This is my conflict of interest statement. This is the outline of my presentation. At the beginning, I will try to give you some information about the monitoring of respiratory support in the delivery room in order to try to adjust our intervention. Then we will move to the NICU, and we try to explain you how to monitor our mechanical ventilation and to adjust our ventilator parameters. And finally, I try to give you some quick reference to some adverse events in course of tract intubation and mechanical ventilation. I think that you and me and all the participants in their NICUs have this modality to guide their mechanical ventilation with some suggested initial respiratory settings, for example, for the RDS, with initial respiratory rate, the initial inspiratory time, and peak inflation pressure and level of PEEP, and then a specific algorithm to contain the mechanical ventilation in their NICU. For example, how to switch from the conventional mechanical ventilation to a frequency when the minimal pressure is too much high, the need of FiO2 is increasing, or to decide during the conventional mechanical ventilation which modality could be much more suitable for the baby. For example, if the baby is able to control absolutely the mechanical ventilation, so for example, you can use a assisted control, or if you want to reduce the activity of the baby, you can switch the baby in ICMV. When there is a very good lung compliance, you can decide, for example, to use a pressure support ventilation. Anyway, the baby that shows respiratory failure may have different pathologies that are underlying, a different chest X-ray that are showing you which is the cause or is respiratory failure. So I think it's very important to try to know the ventilator, and this is pathology, and to try to develop a specific strategy for the pathophysiology that is underlying for each individual patient, and to change the ventilator strategy according to the changing of the pathophysiology. But remember, always try to wean the patients off of the ventilator assistance to try to extubate the baby as soon as possible and to control the baby only with a non-invasive respiratory support, because you have to remember that the mechanical ventilation could be very important in inducing the lung injury. In fact, in the previous my talk, I spoken with you about the risk of ventilator-induced lung injury that is related to the use of very high tidal volume and low PEEP, or using a normal tidal volume but too much high PEEP, or using normal tidal volume but too much low PEEP. We have tried to use an optimal mechanical ventilation that is correlated to the use of normal tidal volume in adequate PEEP in order to avoid both the risk of telectasis and overdistension. We have to remember that mechanical ventilation is one of the most important predisposing factors to develop BPD. We assisted the progressive evolution of the humanity and the progressing evolution of the ventilator. And thanks to the technology, actually, we can monitor continuously the lung mechanics of the baby during mechanical ventilation, thanks to use of a flow sensor. And a flow sensor has to be used, it can be used in the delivery room and in the NICU in our respiratory circuit. This is a very old prototype of a lung monitor used by my friends Steve Dunn in the past. This is our setting in our delivery room. It's not the routinary setting of the delivery room, but sometimes it's used for research, for clinical assistance. We have a respiratory function monitor. We have a volumetric CO2 monitor. We have the use of a respiratory induced plethysmography and a cerebral needs. This is a situation in which we want to monitor lung aeration and also the possible effect on the hemodynamics in this baby, for example, for the cerebral hemodynamics. I think it's very important to try to monitor the lung aeration. And in the delivery room, we can use a respiratory function monitor. This is a display of our respiratory function monitoring in which we can measure the pressure, the flow, and the tidal volume. In order to understand if the data that you are measuring are really available for understand what happens in terms of lung aeration, it's very important to observe the flow trace. And it's very important that the inspiratory flow reach the baseline and immediately starts the expiratory flow. This is our recording with the respiratory function monitor of a preterm infant of 27 weeks of gestational age, birth weight 1 kilo. The baby is managed with a sustained inflation. And you can see that during the sustained inflation, the beginning, the baby was not breathing, then start to have an inspiration without aspiration, then expire. And so it starts to have a spontaneous breathing during sustained inflation. Then the clinicians understood that the baby could be managed only in nasal CPAP. The baby was switched in nasal CPAP alone, or in, I remember was in a mask, facial mask CPAP. Why? Because the baby was able to generate adequate tidal volume, about 4 ml, only supported by CPAP. This is another our recording with a respiratory function monitor. It's always a preterm baby of 27 weeks of gestational age, 1 kilo. At the beginning, the baby is managed with a positive pressure ventilation. Probably the peak inflation pressure was too much higher. In fact, the tidal volume was exaggerated. So we understood that the baby could be managed only in CPAP, and the baby was managed only in CPAP because the baby was able to generate adequate tidal volume, in this case, about 8 ml per kilogram body weight. So I think that the respiratory function monitor could be very useful in understanding if the ventilation is effective or not. And it's very important to observe the flow trace, because in the A situation is a very good situation which the peak pressure that you use during the positive pressure ventilation is able to guarantee a normal tidal volume because there is an in and out of the flow in the airway. B situation and situatory situation are not good because, for example, in the B situation, there is a very high leak, mask leak. In fact, the same peak pressure is unable to generate a normal tidal volume. And finally, in the C situation, the peak pressure was unable to generate a good tidal volume because there is a very high airway obstruction. As you can see, the flow is very, very low, both during inspiration and in expiration. And we know from the literature that the using of a visible respiratory function monitor can help the physician to understand if the baby, for example, during PPV, is at the moment to intubate or not. using a respiratory function monitor visible. These authors in this paper published in 2012 demonstrated that the percentage of endotracheal intubation was reduced when this baby were managed using a respiratory function monitor visible. I want to show you what happens with the other preterm infants, always a preterm infant of 26 weeks of gestational age with a birth weight of 900 grams. At the beginning, the baby was managed with the PPV, with a peak pressure set at 25 centimeter water, but the tidal volume was inadequate, even if the flow was normal. So the heart rate was below 100 BPM. So the question is, have we to intubate infants? Probably if we follow the algorithm of the neonatal resuscitation program, probably we have to intubate the baby, but we decide, observing the respiratory function monitor, that with the increasing the peak inflation pressure from 25 to 30, we were able to increase the tidal volume, and we were able to increase the heart rate and to increase the saturation. So using a respiratory function monitor, we can check in real time the tidal volume that you generated during your respiratory supports, and probably you can understand better if the baby needs to be intubated or not. We hope in the future that the reason to intubate the baby, that is according when the baby is bradycardic, is regulated not only observing the chest movement, but measuring in real time which tidal volume you are able to generate with your respiratory support in the delivery room. Now we can move from the delivery room to the NICU. These are the pulmonary graphics that you can see usually in your ventilator, pressure, flow, volume, the pressure volume loop, the flow volume loop. I think it's interesting what this our colleagues in China concluded in the paper, in which they wrote that probably we are not able to say which is the best modality of mechanical ventilation to use for the respiratory failure of the preterm infants, but the bedside pulmonary graphics are a very important additional tool in association with the clinical examination, blood gas measurement, the saturation and chest X-ray, and for example, the lung ultrasound, in order to evaluate how to manage the baby during the mechanical ventilation. What we can measure during mechanical ventilation? We can measure in real time the waveforms of proximal airway pressure, inspiratory, expiratory flow rate, inspiratory, expiratory tidal volume, and the exhaled PCO2. And we can measure the loops, particularly the pressure volume loops and the flow volume loops, which are the primary goals of this pulmonary graphic measurement during mechanical ventilation. We can identify early change in underlying respiratory disease and infant condition. We can try to optimize the ventilator performance, and we can use a tailored mechanical ventilation approach for these babies. We can evaluate the efficacy of specific modality of ventilation strategy in response to therapy. For example, we can understand which could be the real compliance improvement after surfactant replacement therapy, or we can understand if the resistance in the airway are reduced or not after bronchodilators therapy. And we can detect abnormalities in course of mechanical ventilation, and we can try to reduce the risk of ventilator-induced lung injury, adjusting our respiratory parameters. Which are the clinical application of pulmonary graphics? We can detect inadvertent extubation, high leak occurrence, signs of lung overdistension. We can understand if the length of inspiratory time, expiratory time, and respiratory rate are adequate or not for this baby in that condition of lung disease. We can detect airway obstruction and increase expiratory resistance. We can detect the change in compliance. we can understand if the trigger sensitivity is adequate or not. We can understand if the tidal volume that you set is adequate with the peak inflation pressure that you set on the ventilator. You can detect the asynchrony between ventilator and patient effort. I want to start observing at the beginning the scalar record of the flow. For example, the flow curve could help us in understanding which modality of mechanical ventilation that you are using, because in course of volume limited ventilation, the flow is constant, while during the pressure limited mechanical ventilation, you assist a decelerating flow. It's very important to observe on the flow curve that the inspiratory flow goes toward the baseline and immediately starts the expiratory flow. This is the same what you have to control in the delivery room, because in the mechanical ventilation, when you have this modality curve, you are using an adequate inspiratory time. Because we have to remember that we can have 3 different examples of the inspiratory time. In this case, example number 1, the inspiratory time is too long. In the example number 2, the inspiratory time too short. And only in the example number 3, the inspiratory time is just right, because the inspiratory flow comes towards the baseline, immediately starts the expiratory flow. So the flow waveform help you in choosing the inspiratory time that is right for this baby. And the inspiratory time depends from the time constant, that is the product of the compliance for the resistance. I want you to remember you that the time constant is the time required to fill or to empty the lung compartment, and that we need a single time constant in order to inhale or exhale the 63% of the tidal volume, and that we need the free time constant to exhale the 95% of the delivery tidal volume. And on the display on your ventilator, you have the measure of the time constant in milliseconds, for example, 100 milliseconds or 80 milliseconds. So if you want to choose the right inspiratory time, you have to multiplicate this value for 3. For example, in this case, the inspiratory time that is correct for this baby is 0.3 seconds. But you are helped in understanding if the inspiratory time is right or not, only observing the flow curve. If the inspiratory flow goes towards the baseline and immediately starts the expiratory flow, this flow curve give you the answer. Your inspiratory time is right for this baby. I want to show you what happens in these patients during SIMV, in which the neonatologist choose inspiratory time at 0.45 seconds, 45 seconds. As you can see, the inspiratory time is too long. So the baby was switched from the SIMV in pressure support ventilation. And you can see that the spontaneous expiratory time was shorter, 0.3. So if you want to come back to SIMV, you have to reduce the inspiratory time. And the flow curve are very, very important in giving you the information, which is the optimal inspiratory time that you have to set. In this case, the inspiratory time is too much prolonged. You have to reduce. In this case, the inspiratory time is adequate. In fact, the inspiratory time go up and then go towards the baseline and immediately starts the expiratory flow. The flow curve give you information not only to choose the adequate inspiratory time, but can help you in choosing the exact expiratory time and respiratory rate. In fact, in this case, the flow fails to return to the baseline before the next breath begins. So probably because the expiratory time is too short. you can resolve the situation, increasing the expiratory time or reducing the respiratory rate. It's very important to control this in your ventilation, because if your respiratory rate is too fast, like in this baby, you can see that there is a risk of inadvertent PEEP, and so the occurrence of heart trapping. This is the anti-camera of pneumothorax. If you want to reduce this risk, you have to decrease the respiratory rate to increase the expiratory time, and sometimes you have to consider to increase the positive end expiratory pressure. In this baby, are not right, both the inspiratory time and expiratory time, because both are too short. You had, in order to resolve this problem, you had to increase the inspiratory time and to increase the expiratory time. Observing the expiratory phase of the flow help us in understanding how much are the resistance in the airway. In this case, this baby was affected by increasing the resistance of the airway, because you can see that there is a more prolonged time to allow the expiratory flow to come back to the baseline. How we can resolve this problem? We can increase the PEEP level, you can increase the expiratory time, or to reduce the inspiratory time. In some cases, you had to use the bronchodilators therapy, like you can see in these patients before using the bronchodilator therapy and after bronchodilator therapy. In fact, before to use the bronchodilator, the peak expiratory flow rate is too low and the expiratory time is too much longer. After bronchodilator therapy, the peak expiratory flow rate is bigger and the expiratory time is shorter. The flow curve can help you in understanding how much is the sensitivity of the trigger. In the top of the figure and at the bottom are represented two cases in which the sensitivity of the trigger is too low. In fact, in the top, there is no breath delivered, and in this case, the trigger was ineffective, but also at the bottom, because there are a second breath that is triggered immediately after the first one. So in order to try to reduce this risk, you have to adjust the sensitivity of the trigger. Now we can move to observe the pressure. Why it's important to observe the pressure wave during the mechanical ventilation. At first, because can help you in distinguish which modality of mechanical ventilation you're using. Because during volume limited mechanical ventilation, the pressure curve is ascending, while during the pressure limited mechanical ventilation, the pressure is constant and square shaped. It's important to control the pressure that you are using and the effect on the tidal volume, because you have to remember that when you use, for example, surfactant, and there is an improvement of the compliance, the same pressure that you are using generates a very different tidal volume. And this is very important to control, especially in preterm infants, because in preterm infants, the limits between the functional residual capacity, the tidal volume, the injury score are very undefined. So there is a very high risk that the changing in compliance are responsible or generating a very high tidal volume that can induce a volute trauma. And we have to remember that there is not always a well proportionate between pressure, compliance, tidal volume, because if you triplicate or you continue to increase the pressure, not always there is a comparable, a proportionate increase of the tidal volume. During, for example, the volume guarantee ventilation, observing the pressure curve, you can understand how the ventilator tried to maintain the same tidal volume with a progressive reduction of the peak pressure according to the improvement of the lung compliance. Observing what happens in terms of pressure during the volume guarantee can help you to understand if the baby, for example, is ready or not to be extubated. This is a baby of 1.5 kilo in volume guarantee ventilation with a normal saturation in room air with a tidal volume set close to 4 to 5 milliliter per kilo body weight. And as you can see, the machine uses a same peak pressure that is very, very low, about 15 centimeter water. So the baby probably is ready to be extubated without collecting a blood sample for the blood gas measurement or without performing a chest X-ray. Then we move to the volume. It's important to control the volume, and you have to remember that there is an inspiration phase and expiration phase. In some cases, there are a very big leak, like in 1, 2, 3 example. Only in the 4 example, there is no leak because the inspiration phase is similar to the expiration phase for the volume wave. It's important to control the leak because some ventilator, in some cases, the ventilator is able to compensate the leak, for example, during volume guarantee ventilation, like in this patient, which the expiratory flow area is less than the inspiratory flow area. But as you can see, the tidal volume that you set is maintained by the ventilator by a compensation. Sometimes the ventilator is unable to compensate the leak because the leak is too much higher. So what can we do in order to try to reduce or to avoid this problem? You can consider, for example, to adjust the position of the head of the patient, for example, from the lateral position to the neutral position, or you can think to change the size of the endotracheal tube because in chronically ventilated infants, there is an enlargement of the trachea, and so we had to try to change the endotracheal tube size in order to compensate this leak related to the enlargement of the trachea. Another important information that you can have from the observing of the volume wave, for example, to understand how much is the difference of the tidal volume that is generated by the mechanical breath and the spontaneous breath. At the top, in this baby 1 kilo, you can see that during spontaneous breath, the tidal volume is very, very different from the tidal volume generated during mechanical breath. At the bottom, in another baby, you can see that the tidal volume generated during spontaneous breath is very, very similar to the mechanical breath. Using observation of the volume trace, you can understand, for example, which could be the more appropriate modality of mechanical ventilation for this baby. The baby, for example, is mechanically ventilated with the SIMV, and you can see that the tidal volume generated during mechanical ventilation, mechanical breath, is very, very different from the tidal volume generated from the spontaneous breath. In this case, it's better to switch the baby from the SIMV, for example, in SIMV plus pressure support. In fact, the same baby, when it was managed with the SIMV plus pressure support, was able to generate a tidal volume very, very similar to the tidal volume during the mechanical breath. T-loops, this is a pressure volume loop, and this is the pressure volume loop during spontaneous ventilation. And this is a pressure volume loop during mechanical ventilation. It's very, very different from the previous one. The pressure volume loop can help the neonatology to understand the presence of changing in compliance. For example, in the A example, there is a worsening of compliance in comparison with the B situation. And from the pressure volume curve, you can understand which are the entity of the resistance during inspiration, like in this case, or during expiration. Pressure volume loop can give us some information about the risk of overdistension. For example, the presence of peaking, that is typical when the PEEP level or the tidal volume is too much higher, so you have to reduce in order to try to reduce the risk of pneumothorax, for example. And peaking is often followed by the worsening of the ratio between the C20 and the total compliance. The C20 is the last 20% of the breath cycle, and when the ratio between the C20 and the C total is less than 0.8 or less than 1, this is the ratio that give you information that probably you are very, very close to the overdistension. So you have to reduce your parameters in order to try to reduce the risk of overinflation of the lung. The overinflation could be related to the too much higher peak inflation pressure or too much higher level of PEEP, but could be also related to the using of a too much higher flow. For example, this is a baby in which the flow was set at 8 liters per minute and there is a sign of peaking. Only switching the flow from 8 to 5, you can see that there is a progressive improvement of the pressure volume curve and the disappearing of the sign of overdistension, the sign of peaking. This is another situation, very, very important to detect, flow starvation. This is a typical situation in which there is a asynchrony between patient and ventilator. This is a situation in which the patient is demanding more flow than the ventilator provides. And from the flow volume curves, you can observe the typical figure 8 loop that indicates the flow starvation. These are the flow volume loop. In this case, the expiration is at the top and the inspiration is at the bottom. The lemon shaped is the situation which is a normal flow volume loop. This is the sky slope volume loop. It is a typical in babies in which there is a limitation in the expiratory airflow, typical, for example, in bronchopulmonary dysplasia infants. This is the cigar shape in which there is a limitation both during the inspiration and in the expiration. Is a typical in baby with a subglottic stenosis or narrow endotracheal tubes. This is the bun-shaped curve in which there is a limitation during the inspiration. This present, for example, present in baby with a aberrant vessel that is compressing the trachea. This is a crumpled loop that is observed in baby with very high unstable airways or with tracheomalacia, or mountain peaks that is observed in baby in which there is a presence of airway secretion. This is a baby with a tracheomalacia managed with a too much low PEEP, 2 centimeter water. Increasing the level of PEEP from 2 to 5, you can see there is an improvement of the pressure volume curve and the flow volume curve. This is another baby with a very low compliance, in which the level of PEEP is too much low. And in order to try to open the lung, you have to increase the PEEP. In fact, switching the baby from 2 to 6 centimeter of water of PEEP, you can assist a very important improvement of the pressure volume curve and the flow volume curve. On the left, you have a normal flow volume loop, both during inspiration and during expiration. On the right of your panel, there is a typical situation like trapping. In fact, the expiratory flow no return to the baseline. In order to resolve the situation, you have to to increase the expiratory time, you have to reduce the respiratory rate. This is a sky slope loop in BPD patients before bronchodilator. You can see that the peak inspiratory flow is little. When you use the bronchodilator therapy, you can increase the peak inspiratory flow. This is a situation of turbulence in the our circuit, both in inspiration and expiration. Probably this baby need to be suctioned, or we have to clean the circuit because, for example, we can have the presence of water condense in the circuit. Also, the train data are very, very interesting. The train data about the mean airway pressure used, the tidal volume, the FiO2 needs. For example, in these patients, we have a contemporary presence of the monitoring, the train data of the FiO2 and the mean airway pressure. We can understand really what is happening during the day for this baby in mechanical ventilation. So in summary, which are the practical points of the pulmonary graphics? The waveforms are crucial in course of mechanical ventilation because help the physicians to identify asynchrony, help us to set the optimal inspiratory time, to recognize how to PEEP, to guide the voluntary ventilation, to choose the value of pressure support, for example, during SIMV pressure support. Loops are useful, yes, in order to set the exact level of positive end expiratory pressure, the peak inflation pressure, to evaluate the lab mechanics, to identify leaks, to identify the presence of excessive airway secretion, alteration in airway resistance. But are very, very important, a serial waveform inspection, because help us to identify worsening or improvement of respiratory condition of the patients. Anyway, it's very important, a global approach, in which pulmonary graphics are associated to the clinical examination, blood gas balance, saturation monitoring, transcutaneous monitoring, chest X-ray, and lung ultrasound, because all these tools help the physician to tailor your mechanical ventilation to try to reduce the risk of ventilator-induced lung injury. Always look at the baby, but not just watching. It's very important observation of the baby during our respiratory support. So finally, I want to give you some quick reference to some adverse events that can occur during tracheal intubation and mechanical ventilation. When you try to intubate the baby, you can induce a damage of the upper airway. For example, for the pharyngeal or the esophagus, you can induce a pharyngeal esophageal injury, like in this baby with a pneumomediastinum, with an important air leak. During nasal intubation, you can damage the lamina cribosa, you can give a perforation of the lamina cribosa, you can damage the brain. It's very rare, this condition, but in this baby, the traumatic perforation of the lamina cribosa induces severe IVH and post-hemorrhagic hydrocephalus that require ventricular drainage. When you intubate the baby, you can induce a tracheal injury, you can induce a complication with your endotracheal tube. For example, subglottic stenosis. That is a complication that typically can occur in babies that are prolonged mechanically ventilated. Sometimes the subglottic stenosis is associated with subglottic cysts that need to be managed with the laser therapy. Tracheal perforation is a very rare complication, but has to be considered like adverse events during endotracheal intubation. I want to show you this case report in which there is a tracheal rupture that complicated the endotracheal intubation and was able to induce a very severe pneumomediastinum and pneumothorax. Another patient with a subcutaneous emphysema and pneumomediastinum and pneumothorax that was related to the tracheal injury. atelectasia, pneumothorax, asymmetric lung aeration, ineffective ventilation in the delivery room, trauma to the airway, interstitial emphysema, asymmetric administration of surfactant, are multiple situations that are a sequela of a non-adequate positioning on the endotracheal tube. We have to remember that the distance between the glottis and the carena are related to the gestational age and are related to the birth weight, the dimension of the thorax and the trachea of the baby. And sometimes it's not easy to understand how it's the really position of the tube. So we have to use the reference of the numbers of the tube in order to understand which could be the real position, the right position of the tracheal tube. For example, this is the situation which the tip of the tracheal tube is too much deep and was responsible for this very asymmetrical lung aeration with the left lung overinflation. That is the anti-camera of the pneumothorax. So we have to remember that when you use the tracheal tube, you can induce a decubitus nasal or a commissure injuries that can damage the skin, can damage the mucosa, can induce an infection of the upper airway and the lower airway. Are very, very dangerous, the ventilator-associated pneumonia that are caused by gram-negative or gram-positive bacteria and are especially frequent when the mechanical ventilation is prolonged. More prolonged is the mechanical ventilation and higher is the risk of ventilator-associated pneumonia. And with the occurrence of ventilator-associated pneumonia, there is an increased risk to prolong your mechanical ventilation. So you can induce the risk of bronchopulmonary dysplasia. This is a situation which there is an upper right lobe consolidation in neonatal pneumonia. This is another baby with a pneumatochele in Streptococcus b pneumonia. This is a CT scan in a baby with multiple pneumatochele after Escherichia coli pneumonia. So in conclusion, we have to remember that you can have errors in adverse events during trach intubation mechanical ventilation. You have always to consider that trach intubation mechanical ventilation are extreme solution, and you have to try to avoid everyone. And you have to use the mechanical ventilation only when it's really needed, and to try to extubate the baby as soon as possible with aggressive weaning. Pulmonary graphics, both in the delivery room and NICU, can give important information to adjust our respiratory support and to optimize mechanical ventilation. Complication, adverse events related to trach intubation mechanical ventilation are the trauma of the upper lower airways, infection, the ventilator-acquired pneumonia, and ventilator-induced lung injury, for example, due to inadvertent PIPO lung overdistension. And PPD could be the final outcome of this baby that are not well ventilated. Anyway, remember, always look at the baby, observation or just watching, and underlying lung disease. Thank you very much for your attention.
Thank you, Dr. Lista. We have some questions that have come in, so I'm gonna start with the questions, and obviously to the attendees on the line, if you have any questions, now's the time to start asking them. So the first question that came in was, what would be the optimal trigger level in extreme preterm infants?
We try to, thank you very much for this question. We try to optimize the trigger level. We generally use the higher sensitivity for the very tiny baby in order to optimize the ventilator, in order to help the ventilator to assist the baby during ventilation. So we generally use a high sensitivity. We generally reduce the sensitivity to the trigger only in patients in which there is a risk of severe excessive CO2 washout. So sometimes we reduce the sensitivity to the trigger, or in baby with a seizure, because sometimes baby with a neurological seizure can give a inadvertent trigger to the ventilator, so we can induce a too much high respiratory rate, but it's very, very rare.
Thank you, Dr. Lista. A second question that came in is, what is the parameter, or what are the parameters used in sustained inflations?
Sustained inflation is a very interesting approach that we used in the past in the delivery room to promote the early and adequate functional receiver capacity. We generally use a peak inflation pressure about 25 centimeter water, maintaining for 15 seconds, then followed by a PEEP set at 5. Anyway, I think that you know from the literature that the Cochrane meta-analysis was not happy to allow the use of sustained inflation as a prophylaxis or for clinical assistance in the delivery room, because sustained inflation was unable to reduce the occurrence of bronchopulmonary dysplasia, and in some cases was related to the increased death in a very tiny baby. So actually, the sustained inflation is allowed only in a specific clinical situation, for example, in asphyxiated term infants, or during clinical research, but not during a routine clinical assistance for preterm infants.
Awesome. Thank you, Dr. Lista. Another one as well. We have at least 10 questions that are in the chat right now. So we're going to do our best to answer as many as possible. A question came in: what sedation should be used in neonates for ventilation?
Sorry,
what sedation should be used in neonates
thank you.
for ventilation?
We try to synchronize the baby, so to try to optimize the level of PEEP and the tidal volume in order to try to reduce the asynchrony between the ventilator and the patient. Anyway, when the baby needs to be sedated, we generally use a low dose of fentanyl, and sometimes, especially in term infants that continues to fight with the ventilator, we associate the fentanyl with the midazolam. But generally, we try to use only fentanyl for these babies.
Thank you, Dr. Lista. Let's see. Volume cycled ventilation can be used on an infant that weighs more than how much?
In my unit, the only modality of volume cycle ventilation is the volume guarantee ventilation. And in my unit, we use the volume guarantee ventilation in the majority of our baby, both preterm infants, the term infants with RDS or other respiratory failure. I don't know. I'm not so confident in other modality of volume targeted ventilation.
Another question that came in: is proximal pressure measurement and PEEP setting the same? Are they interchangeable terms?
It's not so easy to answer. I think that probably are not interchangeable. We set the peak inflation pressure, but are not the same for the other term that we are using. You are right. It's not the same. I think they're not interchangeable.
Okay, perfect. Which mode of ventilation to be used in extreme preterm babies? PC, AC, or PC, SIMV?
Okay, good question. I generally prefer to use a assisted control ventilation, PCRC, in very tiny baby, very pretty infants, because the thorax is very compliant, and the lung generally is very stiff. So I prefer to use the PCRC. And when the baby show a very severe RDS or severe lung hypoplasia associated to RDS, I switch the baby from the PCRC to the high frequency. And generally, I use the PCRC plus the volume guarantee with the initial tidal volume set at 5 or 6 ml per kilogram body weight. And we try to tailor the PEEP level in order to optimize my conventional mechanical ventilation. We generally don't use the SIMV for the very preterm infants. When I decide to use the SIMV, probably is around the moment that the baby is during the weaning phase, but for the very tiny baby, in order to reduce the risk of increase the work of breathing, I associate the SIMV with a pressure support. So I combine the SIMV plus pressure support, but during the weaning phase of RDS, or for example, in BPD infants.
Thank you, Dr. Lista. We still have time to take some questions. We have a lot of questions coming in. I just want to inform the attendees, if we do not get a chance to answer your question, don't be afraid. We will send them to Dr. Lista and he will be able to answer you
Yes,
afterwards.
correct.
So
No
a
problem.
question here, what clinical procedures and parameters in ventilator setup need to be checked during the ventilation of transient tachypnea for newborns?
I'm not so I don't generally need to intubate the baby with the transient tachypnea. I think that if this baby needs to be intubated, we are trying to extubate as soon as possible. So I think that during mechanical ventilation, if I can reduce the tachypnea, probably is the answer that your ventilation is adequate. And you can reduce the tachypnea of these patients, increasing the support from the mechanical ventilation, increasing the respiratory rate, and in some cases, increasing the level of PEEP. So I think that this combination of clinical examination and optimizing of the PEEP level can be used in management of this baby during mechanical ventilation.
Thank you, Dr. Lista. So pulmonary graphics are variable in the neonate. How do you choose which waveform or loops to analyze?
Hey, this is a very good question. I think you had to combine the use of the different pulmonary graphics. For example, at the beginning, I give a look at the flow curve in order to optimize the inspiratory time. So remember, I try to optimize the inspiratory time, observing that the inspiratory flow come towards the baseline, immediately starts the expiratory flow. So this is the first pulmonary graphic that I choose. Then I observe, because I generally use the volume guarantee ventilation, I observe if there is a leak or not. And I observe the volume wave, the inspiration in the inspiration phase, in order to understand if there is a leak, how the ventilator is able to compensate the leak. So I adjust the peak pressure, and so I adjust the flow, for example, in order to help the ventilator to compensate the leak. Then I observe the pressure volume loop in order to give a look to the compliance of the baby. This is the modality in which I try to adjust the PEEP level, and I observe the pressure volume curve in pressure volume loop, in order to understand if I'm able to improve or not the lung compliance. Then I observe, for example, during volume guarantee, the pressure trace record in order to understand which is the peak inflation pressure that the machine is using according to lung compliance in order to maintain the tidal volume. So I think that during the day, it's very important that you come back to the bedside and that you control the pulmonary graphics in order to optimize your ventilation according to the changing on the underlying pathophysiology of this baby. This is the optimal modality to try to reduce the time in which the baby is mechanically ventilated, to try to reduce the risk of lung injury.
Thank you, Dr. Lista. You mentioned earlier, I think, something about using volume guarantee. There was a question here about what are the causes of failure in volume-controlled ventilation?
I think that the failure of targeted volume ventilation could be the choice of not appropriate tidal volume, for example, too much low during the acute phase of RDS, or too much higher, so you can induce a lung injury. And I think another cause of volume targeted ventilation is not adequate use of PEEP level, because the targeted volume ventilation need to be helped by the research of the optimal PEEP. And finally, in some cases, in some BPD infants, for example, it's not easy to choose the optimal tidal volume, because many BPD infants need to research the optimal combination, the optimal tidal volume, the optimal inspiratory time, and the optimal respiratory rate. So sometimes this baby, for this baby, it's not easy to manage the targeted volume ventilation. And last but not least, a severe lung hypoplasia, in which the target volume ventilation, but the conventional mechanical ventilation, could be not safe and efficacy, and you have to switch the baby, for example, to a frequency inspiratory ventilation.
Perfect. So a question on non-invasive ventilation. What do you think for non-invasive ventilation, high flow oxygen in neonates, and when to go with invasive ventilation?
About the non-invasive ventilation, high flow, it's correct. Yes, high flow. Yes. I love very much non-invasive ventilation approach. I try that it's important to try to give a chance for all the preterm infants. All the preterm infants that show you that has a good spontaneous breathing could be managed at the beginning with a non-invasive respiratory approach. But when the baby show a very high work of breathing, high need of FiO2 in the first hour of life, it's very important to give surfactant, for example, if there is RDS, and to understand that probably the baby need to be switched from the non-invasive ventilation to mechanical ventilation. High flow therapy, I appreciate very much high flow, but I think that actually, especially in the acute phase of RDS in very preterm infants, is inferior that, for example, to the nasal CPAP or the nasal ventilation. I appreciate the use of high flow nasal cannula for late preterm infants in the acute phase of RDS, for example, for the not so severe severity of RDS, or during the post-extubation phase. This is a very good option. And also for term infants with or late preterm infants with a transient tachypnea, for example.
So to stay on ARDS, and I think you actually maybe kind of already answered this, and this will be our last question. The question was, in neonatal ARDS, what should be the ventilatory setting in RDS cases?
Depends. If the RDS is related, for example, to mechanical aspiration syndrome at the beginning, we try to reduce the tidal volume, to try to reduce the PEEP level, and to adjust inspiratory time. When this baby, for example, with mechanical aspiration syndrome, develop an RDS with a severe surfactant deficiency, is around the moment for this baby to adjust it, to increase the PEEP level, to increase the respiratory time, to try to increase the tidal volume, and when necessary, to give surfactant. But probably one baby is different from the other ones. It could be interesting to look at the chest X-ray and look at the clinical condition of this baby in order to set the more appropriate parameters.
Thank you, Dr. Lista, for the presentation. Thank you for answering the questions. We have answered 12 out of 30 questions.
No problem.
So,
you're welcome. I will try to answer to all the people. If you send to me the question, I try to answer as soon as possible. Okay?
Absolutely. We still have 18 open questions, so I will send them on to you and we'll let you reply to the different individuals.
Okay.
Thank you very much, everyone, for attending. And thank you again, Dr. Lista.
Okay.
It was a pleasure.
Bye-bye.
Thank you.
Bye.